I have this core belief, and I think a lot of people have this belief, that you shouldn't make money off of somebody being sick or injured. And yet in America's healthcare system, you make money off of people being a recurring revenue stream. If you're not making money off them, then your business could go out of business. And so that's the issue we kind of run into. We don't have value-based care. We got fee-based care here in America. And we need to bring more of the Netflix model to the healthcare space.
Welcome to Paper Napkin Wisdom, where we share pearls of wisdom shared by some of the world's top entrepreneurs, leaders, and difference makers. Here's your host, Govindh Jayaraman.
Hi, I'm Govindh Jayaraman, and this is Paper Napkin Wisdom, episode 385. There are things in your business right now that are working, and sometimes that's exactly what makes them dangerous. Because something that isn't obviously broken doesn't get fixed. And when something's failing, you pay attention. So when something still works well enough, though, when people have learned how to live with it, that's when the cost increases a little every year. And everyone around you tells you that that's simply how the system works. It becomes a very easy thing just to stop questioning it and move on. And perhaps you can already think of a list of things that meet that criteria in your own business or life. A process or a relationship, a compensation model, a product, a way of thinking that helped build the chapter that you're in right now, but may not belong to whatever chapter comes next. So today's guest wrote something on his napkin that I haven't been able to stop thinking about. Make yourself obsolete before someone else does. And underneath it, he wrote the word healthcare. So my guest today is Dan Cosgrove, who's the CEO of Better Benefits USA, a nonprofit working to rethink how employers approach healthcare benefits in the United States. But it's a model that just doesn't apply to the United States. It's a thinking that could apply everywhere. Dan has spent time inside of some extraordinary organizations, including Procter Gamble, Berkshire Hathaway, and Nike. And eventually he found himself on the other side of the table as an entrepreneur, as an employer, and someone who's trying to attract and retain great people while looking at the cost of healthcare and asking a question that many leaders eventually ask. Why does this keep getting more expensive if it isn't necessarily getting better? And that question sent Dan into the tax code, compensation structures, insurance economics, preventative health care, and all of the incentives that sit underneath a system that most employers just inherit or sift off to a service provider. And what he found was absolutely fascinating. Because sometimes the people helping you reduce a cost can benefit when that cost increases. And sometimes complexity protects an existing model. And sometimes the opportunity to create something better begins when you stop asking how to optimize the system you inherited and start to wonder whether you could continue participating in it at all. Now, this conversation is sort of about healthcare, but as you listen, you may begin to notice that it's also about something much, much larger. It's about the courage required to replace something before circumstances replace it for you. Kodak didn't do that, and Netflix did. And somewhere inside every established business is probably a version of that decision making or waiting to be happening. Something worked and something still may work, and something that you perhaps have been extremely good at doing continues to work. And maybe the next chapter requires you to become willing to become part of what makes it obsolete before somebody else does. So this is Paper Napkin Wisdom. I'm Govindh Jayaraman. Let's dive into my conversation with Dan Cosgrove. Dan, welcome to Paper Napkin Wisdom. I'm excited to have you here today.
Hey, Govin, thank you so much for having me. I'm very excited to have this conversation.
So you're talking about something that's near and dear to me, but But I love the perspective that you've taken about it because I think it's just an interesting way of framing the conversation. So make yourself obsolete before someone else does, and then you put a little hyphen about healthcare. So why did you share that with me?
Well, everybody that's probably been to like business school has heard like the Kodak story, right? Where Kodak was dominating it in the photo space, and somebody with internally in Kodak recommended, hey, we should probably work on digital photos because that's where the new frontier is. And they all buried their heads in the sand. And now we know Kodak doesn't really exist anymore. And so I've always looked at that as like, okay, would I rather be Kodak or the group that disrupts Kodak? And I definitely want to be the group that disrupts Kodak. So now as we tie that to the healthcare space, I personally believe we live in the greatest country in the world in the United States, but our healthcare system is less than great. And it desperately needs to be disrupted. And so my goal as a nonprofit is to make them obsolete because they're certainly not trying their best to try and make themselves obsolete.
So, one of the things I think is interesting about what you said. Well, first of all, you talked about the Kodak story, and that's a famous one. And that, like, the counterpoint story to that is Netflix, right? Netflix was shipping CDs all over the place. And for people who don't believe this, it's true. I mean, you can Google it. Because I was a member of Netflix back in the day where you get DVDs in the mail and then get to watch them with no late fees and then throw them back in the mail and you got another one. And they abandoned that. They were rocking that and moved right out of it to streaming when streaming sucked, right? Like streaming was very difficult at that time, but they still figured it out, went through the growing pains and did it. So that counterpoint, Kodak didn't do it. Netflix did do it. We still do. Most of us are doing business with Netflix today, and buying their services, but almost nobody's buying from Kodak today.
Well, and think about that though. Netflix did it. Blockbuster didn't. Or in Hollywood Video didn't do it. So Netflix disrupted that initial part. And I think it's just their internal thinking. It's like, okay, so we disrupted this part. Now we need to figure out how to disrupt ourselves before somebody Netflixes us. And so, yeah, I love their model. And truthfully, a lot of what Netflix does is what I'm trying to bring to the healthcare space. So
it's very cool. But but I think there's two parts of the healthcare space that's really interesting. And I really wonder about this because I think they sort of are fighting with each other a little bit. And I'm curious about how you feel about it, because on one side, there's the healthcare delivery model. And then there's the other part of it, which is actually the hospitals and systems and structures that provide the institutional service. And I think when most people talk about the system being broken, they're talking about the delivery model, not the creation model, not the hospitals themselves. Like, hospitals do a great job of solving acute problems, which is really what they're built to do. But it's the delivery model of that in an equitable way that I think is what you're talking about. This doesn't exist.
Yeah. You're pretty spot on. I mean, I have this core belief, and I think a lot of people have this belief, that you shouldn't make money off of somebody being sick or injured. And yet in America's healthcare system, you make money off of people being a recurring revenue stream. If you're not making money off them, then your business very well could go out of business. And so that's the issue we kind of run into, is we don't have value-based care. We got fee-based care here in America. And we need to bring more of the Netflix model to the healthcare space. And really what I mean by that is, whether you watch one show or 100 shows on Netflix, you're still paying the same amount each month, right? Like, doesn't change. What if we did that with healthcare? Whether you see one doctor or 100 doctors, you still pay the same amount each month. That is value-based care. And that's actually how you have a better preventative healthcare system here in America. Because what we've seen over the course of time is, because insurance premiums continue to climb, people move into high deductible plans. Well, now they really have their insurance for catastrophic purposes. But now if you have like that little cough, nope, you're not going to do anything about it until potentially it's too late. When that little symptom, that if you simply just had access to an on-demand doctor 24/7, 365, that little symptom could have been addressed as a little symptom and you could have gotten the medicine that you needed. Instead of it turning into a major chronic condition, which costs the American economy $4.5 trillion a year. So yes, I have a very big issue on how our healthcare system is structured, of making money off of fees or a fee-based system where people are viewed as a recurring revenue stream.
Hey, I'm running out to drop off a stack of letters and packages. Need anything shipped while I'm gone?
Save the gas. Stamps.com lets you print postage and schedule pickups right from your desk. Sync your contacts into the address book, get detailed accounting insights, and get notified the moment your certified mail is delivered.
All from my desk?
All from your desk.
Join the 4 million businesses using Stamps.com right now with code PODCAST and get your free welcome gift. Stamps.com, code PODCAST. Taxes and fees apply.
And maybe that's part of the service delivery model that's really a challenge because, one of the things we talked off at the top is that hospitals, for the most part, are really built around acute care. And I want to give you, a contemporary example from my family. About 2 weeks ago, my eldest son was involved in a head-on collision and, he needed acute care. And man, I've been in awe ever since at the level of care that he received from an acute basis. I thought it was really impressive. But the lingering parts of his care, no longer now acute because, he's going to be okay and he's fine. And I think the biggest complaint he has is that he'd like to be better so he can do more.
Sure.
So that's a good thing.
Yeah.
But, his concussion symptoms and things like that, the things that are lingering, there is less acute need for somebody to intervene right away. And so there's less care. And you're sort of reversing that a little bit and saying, hey, if we took care of the little coughs, sniffles, sneezes, and the smaller stuff, it doesn't turn into as many big acute things. And maybe the system works better for everybody, right?
100%. Yeah, absolutely. Because 2/3 of Americans have at least one chronic condition.
Oh, that's a crazy number. Just let's settle in on that number before we skirt over. That's a couple 100 million Americans that have some version of a chronic condition, right?
Yep. And guess what? When you have chronic conditions, they're a recurring revenue stream, especially where you have vertical integration between the PBMs and the insurance carriers. So, and if we know the PBMs, they've been sued by plenty of state attorney generals for inflating the cost of healthcare. I personally don't think they have the best interest in mind for the everyday American. I think they have the best interest in mind for their own profit and loss statements. And so, we want to, and is it going to be solved tomorrow night? No, it's not. You need to put in place a preventative healthcare system where people now proactively manage their health. So that 10, 20 years from now, you have less chronic conditions. And from an economist perspective, let's just think about this. The American economy increases its government deficit by about $2 trillion a year. We spend $4.5 trillion a year on chronic care conditions alone. If we simply were more in line with the rest of the developed nations in terms of preventative healthcare, giving people better access to healthcare when it's earlier on, rough estimate, we reduce about 50% of this chronic care costs of the future. So instead of $4.5 trillion, you're looking at $2.2 trillion. Well, that right there, we just found a way for the U.S. government to pay down its government deficit instead of increasing it by about $2 trillion a year. So that's the importance of it. But again, it's such a long process and everybody wants an overnight win. You're not going to get an overnight win like this. It's a habit change for millions upon millions of Americans.
So for people who are not aware, you've used an abbreviation a couple times and I understand it because I'm going to get to how I understand it in a second. But what is a PVM? Give me an example of what that is. And
prescription benefit managers. Yeah. Yeah, so the BUCA is another acronym, Blue Cross, United, Cigna, and Aetna. They pretty much have vertical integration with a whole bunch of prescription carriers. It's another way for them to boost their profit margins. Because here's another fun acronym. Insurance carriers have to operate under MLRs, medical loss ratios. Well, they're smart, They've had the big three consulting firms all work with them in the past. They know how to funnel more of those profit margins outside of the insurance carrier purview and into subsidiaries that are not subject to medical loss ratios. PBMs just so happen to be one of the plays, but it's a great way for these companies to continue to make more money and not help any American.
And that's a huge deal. So what is that? So because they're moving this profit to these PBMs, what's the impact to people like you and me, Dan? Like, how does that hurt us? Because I think what they're out there saying is, oh no, this is just part of the business model. Nobody gets affected by this.
Yeah. So let me give you a scenario here. Let's actually talk about medical loss ratios. So people can understand this. Let's just say what a medical loss ratio means is if you're paying $100 in premium a month, $85 of that has to go towards medical care. That's really what a medical loss ratio means, which means the insurance company can only keep $15 worth of profit. So if we start first on the medical loss ratio, the only way for an insurance company to increase their profits, which we know that's always in their best interest, is to actually convince the medical providers that are carrying their insurance to increase their cost of care. Because now if let's just make it up, that family doctor was originally $100 to see, now you bump them up to $125 for the exact same procedure next year. Well, that now means the medical loss ratio on a percentage basis stays the same, but the total dollar amount grows. So that's the first part. Is we often think insurance companies are trying to negotiate with hospital systems and medical providers to reduce the cost of care. They aren't. They are not. If you're on a fully insured employer plan or a self-insured employer plan, it is not in the insurance company's best interest to reduce the cost of care, because based on how the medical loss ratios were written, they only make more money if they convince people to pay more. Right. And it's stupid. So that's the first part on the MLR. And I'll pause there to see if you have any questions there, because that's just like one facet of all the things that they do in this very intertwined and confusing network.
Right. And it's really important to understand that what you're talking about is, and I want to put it in a very simple way that everybody can understand. Because they can only make 15%, right? Only make 15%. Their best interest is to get the 15% on a bigger pie.
Exactly.
It's not $15 out of $100 anymore. It's $30 out of $200. And because 85% of it's passed through, quote unquote, and we're going to get to that pass through in a second, but because 85% of it's passed through, what they've done is if they get those numbers, those top line numbers to go up, then their 15% goes up. And that's how they make more money. Absolutely.
Exactly.
Right?
Exactly. Yeah. If you want to see something really fun, health shares have taken off in the last 15 years after the creation of the Affordable Care Act. And for people unfamiliar with health shares, I'll just give them the quick overview on that. Health shares are not health insurance. In my opinion, they're better. Because what a health share is it can actually deny letting people onto their health share plan if they have pre-existing conditions or are just generally unhealthy individuals. Well, that means the risk pool for a health share is significantly lower. So I'll give you a personal example. In the state of Massachusetts, where I live, for my family of four, for a $2,500 deductible, it's about $2,200, $2,300 a month. I can get on a health share for the exact same deductible. Now they call it an unshareable amount. But I can get on a health share for about $750 a month. That is significantly lower. And you have access to the same networks of providers.
That's a house in between those two for many people.
Yeah, exactly. And guess what? In the state of Massachusetts, it's one of the 5 states where it's actually illegal to not have health insurance. So I pay a fine of $2,800 a year. Well, if I'm saving about $1,500 a month, by March, I'm already break even. Right. So it's wild. But what I like about health shares is you present yourself as a cash payer. People think when they're using their insurance that they're getting the best negotiated rate. No. When you present yourself as a cash payer, the cost you are paying is significantly lower than what the pre-negotiated insurance rates are. People just don't know that. And nor should they. They should. A lot of us believe and trust that other companies are doing what's in the best interest of, me, the member. But that unfortunately is not the case with our healthcare system. And that's why we spend so much time trying to just educate people. And like, you have all these options out here, but you're probably just not aware of it because you already have your 9-to-5 job and probably raising a family and doing other things. Like, you don't have enough time to try and figure out our very broken healthcare system. Right.
It becomes very, very, I mean, it's just another thing to manage, another thing for people to do. All right. So we've talked about medical loss ratios. Let's move on from there.
Sure.
To the next stage of complexity, because there's just nothing but complexity here.
Oh my gosh. Yeah. Well, how do insurance companies make money?
Like, how do they make money?
Create complexity. Like, if I liken this, I did a LinkedIn skit on this, several months ago. But I likened it to the movie The Big Short that talked about mortgage-backed securities. And when you look at what was going on in that market back in like 2008, there were so many acronyms, so much confusion. Nobody understood what like the underlying products were or anything like that. And they were making money purely off of confusion. That is what our health insurance marketplace is now. There are so many acronyms. There are so many different third-party administrators or different vendors involved in your process. You've got pre-authorization for this, but not for that. You can only see this provider, but not that provider. These prescriptions are tier 1, but these prescriptions are tier 4. Oh, and these prescriptions aren't even allowed. Oh, and also they've got an algorithm in place where I think it's about 11% of all claims are just automatically denied. Look across all of the insurance vendors, and really it's like 11% are denied. No rhyme or reason. How can every single insurance carrier have that? Because they have it down to a science. Because they know if they deny it, they know the majority of people, again, because of complacency and just not enough time in the day, majority of people do not want to have to deal with an insurance carrier and have to deal with the follow-up. So they know if they deny 11%, only about like 40% will ever do any follow-up, which means 60%, they just avoided having to pay any medical claims. Like, it's, and that's just the tip of the iceberg. Like, how can you go in, like, show me any other business in the world where you're going to come in for service or buy a product and you're not going to know the cost of that product or service until about 60 days later when you get the bill. You're just like, oh my gosh, I went in just to get a blood panel and now I'm paying $400 for it. Like, what? Like, no other industry would be allowed to operate like that, but yet our healthcare industry is.
Right. So one of the things that I think is also really interesting about this model, Dan, and this model of healthcare that exists in the United States, and you started off this, and in the green room before we began, you noted that I live in Canada, and we're talking about U.S. healthcare predominantly here, and one of the reasons why I know something about it is because I've done a lot of business in the U.S. and been involved in a lot of business in the U.S., so I've seen those models. But the other side that I know something about it is that we built a platform many years ago, which is diabetes prevention, and the diabetes prevention platform was designed to help people who were pre-diabetic make the lifestyle change choices that would help them, sort of prevent or prolong the period before they become diabetic eventually. And it's a really successful program. There's a CDC program that supports the funding of it, and it's available across the United States. It's one of those, again, amazingly underutilized programs that exists in the country because it's in the area of prevention and in the area of behavior change, which are two very big problems that sort of coexist around wellness. Without getting into that, one of the things that I also have observed over the years about the difference between the health system that exists in the United States and everywhere else in the world is it's so complicated, so expensive, and it's literally the only place in the world where there is some general lack of guaranteed universal health care. So it's all punted to the individual,
correct, which
then many employers sort of come in and take up space to try to help people with it. Yeah. But employers aren't good at it either. So everybody's in this opaque, let's try to make the best of this really difficult situation. that's been created structurally, and everybody's got these, literal Band-Aids on various parts of it. And you're trying to, and, even you who are, you're an expert in this, as you talk through it, it's easy to get mixed up or confused as we're following you around MLRs and PBMs and every other acronym that exists underneath the sky. So what do we do? How do we obsolete this mess?
Oh man, there's so many different paths to go down here. We could go for weeks on it. I think there's a few things that have to change. Let's start with step one. The compensation model needs to change in the industry. Currently today, you have your insurance brokers or benefit managers, whatever you want to call them. And they historically make a percentage of commission off of the premiums that the employer pays. Well, that creates a conflict of interest, in my opinion. If somebody's going to make 5% off of premium, if it's $100, and all of a sudden they say, rates are going up. I negotiated with the insurance companies to keep it down to only a 15% increase. Well, did they really? Because they just got a profit increase. So I do believe all benefit managers and insurance companies should either have to work off of a fixed PEPM, so that they have a vested interest in it doesn't matter what the amount the client's paying, or they should work off of a percentage of savings they generate for the client. And that's personally how my nonprofit operates. Is like, we call it a gain share model or a sustainable funding model. We're just like, if we don't save you money, we don't get paid anything. And as a nonprofit, we shouldn't exist unless we're delivering real value. So I would like to start first on like the people that are selling and administering these types of plans, either going off of a fixed PEPM or actually getting paid on a percentage of the savings. They shouldn't get a commission off of how much they convince people to overpay. That is the first part I would change. If you want me to keep rolling, I would also then, now that you have that in place, I would focus more attention on the type of insurance plans the employer or employee or individual person is enrolling in. Right? I already made the statement on health shares. I think more people need to look into them. You have to get more comfortable with them, but they're good.
One of the things that I'm thinking about that might make this easier for people to understand is if we go back to your napkin.
Yeah,
right? You say make yourself obsolete before someone else does. And I'm curious how this really, how did you learn that message? Like, where did that wisdom come from? Because I think if we get to this origin of where that came from, I think we can see better how you're applying it, because healthcare is so complicated. And I think you're making sense of the complexities and even making some suggestions around where people could create opportunity there, and where the opportunity exists, and where the opportunity exists that you're going after.
Yeah.
But how did you get there? So, where did you gain your wisdom around obsolescence?
My wisdom honestly comes from the corporate world. I was at Procter Gamble for a number of years, and we were always working on, I'd say, the front end of various things that we can do in terms of monetization with the know-how that we have. I then ended up getting poached, I moved over to Berkshire Hathaway after they sold my brand Duracell. So I learned some more things there from Warren Buffett. And then my final corporate stop was Nike. And I was the CMO I was the assistant to the CMO. And so I really got to be, or the chief of staff, whatever you want to call it. I spent so much time sitting in those meetings and learning from great executive leaders. And I was actually, right before I left there, I was working on a business plan that truthfully was going to disrupt the Converse and Nike business. And it was, I forget which the executive was when I made the pitch. It was just like, man, I like this. I like this idea of making yourself obsolete before somebody else does. Now, ultimately, Nike did move forward on it. So there's a difference of opinion, you could say, which is ultimately why I ended up leaving there. And look at what Nike stock has done since. But I feel now so vindicated now over the past couple of years, seeing what everybody's saying. It's just like, oh, yeah, Nike shouldn't have done that. And I was like, yep, you're kidding me. So it was working off of these things in the corporate world that I then, truthfully, I stumbled my way into the healthcare world. I have just as background, I have a very German background. My mom's name is Ilsa, and I'm one of 3 kids, and we're all 3 years and 20 days apart. So I work off of a pretty tight schedule. And so I had originally set a goal when I left University of Richmond that within 10 years, I wanted to break away and do my own thing. And it's specifically, I wanted to do my own thing in the healthcare space. So the stars just like perfectly aligned. Like I was at Nike during COVID, packages were being given out. I got a package. It was awesome. It was at 10 years and 1 month that I got this package. So I missed my target date by 1 month. Well, I started first in mental health, and I have now a nonprofit there as well called Mental Health Matters, and we've got about 40 employees. Well, for a lot of business owners out there, like when you're focusing on a company, your true success lies in how well you're able to attract and retain talent and really care about your people. Because if you don't have that, you have no means of actually succeeding. Well, like any business owner, my first year, I was barely keeping my head above water. I was doing the same stuff that a lot of people are doing today in terms of employee benefits, providing all these rich packages. Well, guess what? Like your expenses can't grow faster than your profit or your revenue. And unfortunately, that's what a lot of people are doing right now. A percentage of expenses are growing faster than revenue. Eventually, they're going to make themselves not sustainable. And so I went down this massive rabbit hole, again, being the son of 2 lawyers who likes to challenge the status quo. So I read through tax codes. I read Tom Wheelwright's book, Tax-Free Wealth Strategy. And he wrote in that book, about 95% of the tax code is actually written in our favor, but every American is fearful of that 5% really in the April tax day. So I worked off of these various hypotheses and put all these various things together. And like, remember even my first job at P&G when we were working on a program called Salary Sacrifice, I was like, there's got to be something better. And so I piloted and I tested it on my own people, and it worked out. We saved directionally about $3,000 a year per employee, and gave them at the same time better benefits. So working from that about 4 years ago, we've now taken this to plenty of more clients and their respective employees in hopes that ultimately employees can close the gap on care, cost, and coverage because they're working so hard. They deserve better access to healthcare. So that's a very long-winded way of explaining like how I came to that make yourself obsolete before somebody else does.
Well, I think it's really amazing. And I think that one of the things you touched on, and I think this is a really big part of it, is so many companies struggle to attract and retain great people.
Oh, yeah, absolutely.
And to that point and to that end, I think a lot of people who want to be great employers and a lot of people who think they're doing the right things are signing up for healthcare programs and healthcare insurance that is, they think is really serving their teams. Really, they think they're doing the right thing by them. And I think that what you're saying is, even though they think they're doing that, very often they're not. They're sort of contributing to the same problem that is persisting over and over or growing.
Yep.
Isn't that true?
It's very true. It's 100% true. Because also in America, I think we're the only country where health insurance has been pushed on to employers to pretty much subsidize. As a result of that, HR gets tasked with a nearly impossible task. Like HR is in charge of compliance. They are not here to figure out math equations that are pretty damn complex when you think about our healthcare landscape. But because employee benefits is not a really sexy topic, the CEOs, CFOs, and CEOs really don't have an expressed interest in it. So they pretty much just say, hey, HR, go figure it out. And then what does HR do? They say, hey, our third-party benefits manager, can you help us figure this out? And they forget that the third-party benefits manager doesn't have a fiduciary responsibility to them. So that all they're doing is they're asking the group that is overcharging them to help them figure out ways to solve it. You're destined for failure. And that's really the biggest issue that employers are facing is they have to, in my opinion, they have to reframe the opportunity for them. And the best way to reframe it, let's just pretend, we'll make this up, 100-person company. You operate on a 10% profit margin. Well, and let's just say we can save you about 100,000. If it's a 100-person company, low side, we're going to save them 500, high side, probably about 3,000. So let's just go right we'll make it conservative, $1,000 saved per employee per year. Well, that's $100,000. If you operate on a 10% profit margin, That's a $1 million sales opportunity. That's what gets CEOs and CFOs excited, is $1 million sales opportunity. So we have to almost reframe it as like, this is your biggest sales opportunity and you don't even have to go outside your four walls.
Right. And like, just put that in context. An average 100% company is probably doing somewhere between, let's say, conservatively $12 million to $15 million in revenue.
Yep.
So the other side and the other way of thinking about this is that you're essentially finding a way to grow revenue or grow your EBITDA,
grow profit. Yeah.
In a somewhere to 8 to 10% level, like you just said, off the top, very easily. It's like adding another million or two to the revenue line, as
Exactly.
you also talked about. The other thing that I thought was really interesting about this that you said off the top is that the U.S. is literally the only place in the world where employers are responsible for healthcare. And I remember traveling in in Asia at one point and doing a business conference tour, and I was speaking at various places, and I understood that employers in many of those countries are responsible for opening bank accounts for people. So people can't, in some of those countries, get bank accounts unless their employers literally signing off for them that they can have a bank account, which is outrageous. When you think about independence of people and their ability to move from one employer to the other, when one is holding your right to have a bank account in their hands, it's pretty powerful. But the extension very quickly became, wait a minute. In the U.S., we're dealing with a system where, I've got portability of my bank account, but not my health, and that's a big deal. If you're thinking about hierarchy of needs, that's very close to safety, isn't it?
Correct. Healthcare, I think, is a human necessity that every person has the right to have, and there are means to being able to provide it. But when you have our healthcare complex, there's a lot of money there, and you got a lot of lobbyists and a lot of employment. And we also look at the employment numbers on a quarterly basis here in America to dictate how the stock market's going to do. Like, if you truly tried to restructure it, it'd be nearly impossible to do. Like United Healthcare's group CEO, after the unfortunate killing of their United Healthcare CEO, he wrote an op-ed in the New York Times saying, "Hey, we didn't build this system. This is a system put together by patchwork policies. Like, we think it needs fixed too." And this is United Healthcare, the biggest group out there. So like, they're admitting something's wrong, but they're not trying really to do anything about it because they're making a ton of money off of it. And so that's why this industry is so ripe for disruption, because you look at the level of frustration by employers and employees. Like, you shouldn't get your medical bills denied just because of an algorithm. Like, that's stupid. And you shouldn't be overcharged on health insurance premiums. It just doesn't make sense. And here I'm going to say something crazy. Subsidies shouldn't exist. Because when you create the subsidies, all it's really doing is it's going into the insurance company's pockets, not the individual American.
That's interesting.
I'll give you a prime example. And I know this is probably going to, polarize some people, but let's look at Kaiser Permanente. I personally love how Kaiser Permanente is structured. I wish they were at all parts of the United States. But I'm going to give you another example of, let's pretend you have a family of 4 in Houston, Texas, or somewhere in Texas. Then you got that same family of 4 in Los Angeles, California. Most people would say Los Angeles is a more expensive place to live. Now, that family of 4 in Texas is going to pay a little over $3,000. Again, we can make it up, say it's a $2,000 deductible plan. That same family of 4 is now going to go to Los Angeles, and for the same size deductible, they're going to get that for about $1,800. How in a higher cost of living city can they pay about $1,200 less? It goes into how are the insurance companies structured. In Los Angeles, you've got players like Kaiser Permanente, which keeps people honest. So Kaiser is an insurance carrier, but also the medical provider. Kaiser's not in a state like Texas. So where the insurance companies make their money in Texas is truly just inflating the cost of premiums because they don't actually have the providers there. That's my problem with subsidies, because subsidies are ultimately just justifying premiums being jacked up. If you force more true vertical integration in the good purposes of having the medical providers tied to the insurance plan, like Kaiser is structured, you would actually have lower cost of care. Because Kaiser's best interest from how all the profit is spread is actually creating good patient outcomes, aka value-based care, not fee-based care. Now, is it perfect? No, it's still not perfect. But the premiums alone are what I'm trying to attack because I don't think people should be overpaying on all these various things. And we currently are with how the system's set up.
One of the things that I think is also really interesting about your story, Dan, is that, you came into this as an entrepreneur, right? You came into this because you had your mental health organization, Mental Health Matters, and 40 employees. You were trying to attract and retain people in a nonprofit and trying to find a competitive advantage in doing that and couldn't find one, right? I assume you went into the market looking for health insurance programs, couldn't find one, and then decided, I'm just going to build a different way.
Correct. Yep. And it's worked out nicely for us. Like we've got about, the mental health industry has high turnover, like maybe 70% retention. We sit at around 95%. We've gotten plenty of industry awards. I think 2 years in a row now, Massachusetts Top Employers, Inc. We're less than 1% off of being one of the best workplaces in America, but we still outperformed any mental health facility under Inc. rankings by, I think, 7% was the closest one. So we've done good things there. And again, we rewrite the approach to employee benefits. Our approach is providing an amazing benefits package to our employees, but just don't overpay the broken healthcare system. And it's through creativity and understanding how the U.S. tax codes are written and understanding where all the middlemen are making their money that we are able to put in place packages that our employees actually enjoy and that we as the employer aren't overpaying on. And so I just take those exact same strategies and I give that to other companies as saying, hey, up to you. You can stick with the status quo or you can try and change things. And guess what? Unfortunately, a lot of people, they stick with the status quo because show me any HR person that's ever been fired with sticking with the status quo.
Right.
I haven't.
Yeah, mitigating risk is something that's real. And for a lot of companies that are fighting, next quarterly report, and this mentality is, one of the things that I think drives stagnation and risk aversion and a lack of innovation everywhere because you're just fighting for the next quarter. In what you've done instead is take a longer term approach, but really designed it around your 40-person shop, which I think what's really interesting about this is I think there's a narrative that says small companies can't compete with big when it comes to a healthcare solution and a health solution for their team. And you're literally riding your thumb at them and saying, we can do this. You're wagging your finger saying, no, what are you talking about? I'm competing and I'm winning. One of the best employers in America. But most importantly, and I think this is the thing that you skirted over, you were best in class. You're in your industry, you were best by a fair margin. And all while doing this as let's say call it an undersized organization. So again, you're using your knowledge of the system to question assumptions and really create obsolescence around this old way of doing things. And who are the people that benefit? Your team. So you've solved the problem for your team, right?
Correct. But my goal is not to just solve the problem for my team. My goal is to solve the problem for all the small to medium-sized businesses out there because when you look at it, they're the backbone of the American economy. The large employers are great. They've already got things solved. Trust me. From my experience over at P&G, we had things solved like 15, 20 years ago when I was there. They're not busy trying to help the small to medium-sized businesses. They're just busy trying to acquire those small to medium-sized businesses for a fraction of the cost once they ultimately cannot sustainably stay open. So my goal is to try and help the small to medium-sized figure out the things that I wish they knew. But again, they don't have somebody there to just give them some guidance because it's not in the industry's best interest to give them that guidance yet. So that's what we're doing.
Why did you do this as a 501c3 nonprofit?
Yep. Because there's a few reasons. Part one, it makes it harder to get acquired. It's not impossible, but it makes it harder for somebody to get acquired if they're a nonprofit. And when you look at a lot of the healthcare innovations that have occurred over the last 15, 20 years, it's a small company and they got acquired by one of the big guys. And now that innovation's pretty much dead. So that's one reason, is trying to make it more difficult for us to be acquired. Part two, we're actually, like, we were just in a conversation with a group today. We take 10% of our proceeds and we donate it back to their cause that's most important for them. And for this group, children's hospitals were really important. So it gives us more flexibility in how we want to utilize the funds. So again, is it a perfect model? No, and it doesn't mean nonprofits don't make money. Like, yes, we all need to make money, as you know, whether you're for profit or nonprofit, but it gives us a cleaner purpose and, I guess, alignment of our principles and values. And that's why we're a nonprofit.
I really think it's interesting. And it's so true in renewable energy, in healthcare, in those sort of the industries of the elephants, for the most part, where innovation occurs in organizations the size of Fly. And I remember I've been in both healthcare and in renewable energy, and I remember always thinking that the giants, we were a fly on the elephant's bottom, and all they needed to do was sit, and we'd be done.
Yeah.
And what you've done is use the 501c3 nonprofit structure as a strategic moat to create acquisition resilience, so that your innovation doesn't easily disappear. I think that's a really interesting thing. So it's like this anti-obsolescence step that you've taken in the structure, while you're challenging the status quo in many other ways. An interesting paradox there.
Yeah. And I personally, I love that we do a gain share model. We offer it, we say, hey, if we save you money, we get paid money. And typically it's a 25% gain share. So that's how confident we are. And a lot of people push back on it. It's like, wait, you're going to take 25%? It's like, show me the last time any employee benefits manager has come back and even given you a flat increase on your employee benefits costs. And it's like, all right, fine. Yeah, I'm looking at 15, 20% increases. So like, once people kind of understand, like, we're only going to get paid if we save them money, they understand that it's in our best interest to provide significantly better value to them and their respective employees. And that's what I really love about how we're structured.
And I think this is a really interesting idea just generally in innovation. If you're coming in to disrupt an industry and you're going to come in any kind of way other than a game share model, you're kind of playing to the champs in the industry. But what you're doing is something decidedly different. It's taking the DVDs out of the envelopes and putting it on the internet. You're effectively distributing it at scale.
Correct.
And saying and aligning your interests very clearly with your clients. And I think that's powerful. That's really powerful. If you were to predict what's going to happen, there's so many things that are happening at the same time right now in healthcare. And one of the things that I think is really fun about it, because I'm more than a casual observer of what's going on in peptides, and I was looking at TB500, for example, and BPC 157 as being two examples that have recently shown up on various athletic associations' banned substances list.
Yeah.
But they're not approved for use. So it's interesting, right, that these peptides are not approved for use, but they've been listed on the banned substances guide by the Olympic Committee and others. So are we saying they're working, or are we saying they're not working? And I think that's a fascinating subject, but there are so many almost population-motivated improvements to wellness occurring simultaneously. People are taking more interest, if not agency, over their wellness, and not just health 100%. And not just their recovery.
Yeah.
How do you see this all coming together in a broth? Like, is it all going to come together, or is it going to separate out some way?
It's already starting that direction. So I'm a big believer in preventative healthcare programs. I believe the industry is going in that direction. And now a lot of people are just like, no way that's going to be allowed, because truthfully, it's a tax deduction. So it's a tax mechanism for employees and employers to save money on their taxes, while simultaneously getting access to, like I said, the Netflix model of healthcare, getting access to prescriptions, like 1,000+ drugs at $0 copay. So that takes out some of the PBMs need, to even getting access to like GLP-1 programs for $225 a month instead of paying $1,000 a month. So like preventative-based care is going in that direction. Now, to take a step back, for all the naysayers that are just like, there's no way in hell that's going to be allowed, I believe this is the third frontier in terms of employee benefits. The first one occurred in the late 70s and early 80s. It was called the 401k. And a lot of people don't know this. The 401k was created as a tax strategy for ultra rich people to shield themselves from taxes. It's why Reagan only acted in 2 movies during the 70s, because the third movie, he was just paying all of the taxes on it. So at that point in time, you were allowed to, I think, put about $50,000 a year in tax-free into a 401k. In today's terms, because of inflation, that's like $250,000 a year. So it wasn't until a few years after the 401k came out as a mechanism for rich people that somebody figured out, oh my gosh, I can put this in employee benefits. And the IRS pushed back on it for several years, saying there's no way you can legally do this. Everybody doing this right now is going to pay tax penalties, et cetera, et cetera. Guess what? That didn't happen. It was ratified in the mid-'80s, in which the 401k is here to stay. So that was the first frontier of employee benefits, of using the tax code to actually give employees better benefits. The second one was this vehicle called the HSA. Started in the early 2000s, I think it was 2003. And guess what? Same thing occurred. People were just like, there's no way this is ever going to be allowed because it's a triple tax advantage. Like, this is going to get shut down immediately. Now the HSA is one of the most requested things out there. And it took a full decade. It was about 2012, 2013, coming out of the Great Recession and deductibles going up and the Affordable Care Act occurring, that people were just like, wow, the only way we're going to afford this is if we have an HSA or a high deductible plan. And that's when people started getting behind and saying, okay, HSA is here to stay. So it took a decade. So then these preventative care programs, they started under the Affordable Care Act amendment in 2016, 2017. And truth be told, they were poorly rolled out, just like any government program. So you had a lot of bad actors. But now here we are 10 years later. The IRS had their tri-agency agreement in 2024. The Chevron doctrine was overturned in 2024, saying the age of agency overreach, aka the IRS, it can no longer unilaterally try and make rules, since we know that falls on Congress to do. Well, you still have the main players, the Blue Cross, the United, the Cigna, the Aetnas, and all the brokers tied to them. They're still pushing back on it. Why? Because it will cannibalize their profit margins. So that is where preventative healthcare is going. And I'm a big believer in it, but it does take people, again, from their risk management perspective, to understand what's really going on versus what their benefits broker is telling them right now. Because the truth is actually in the facts, objective facts, not somebody's opinion. And that's where a lot of people are getting confused.
And one of the things that I think is so delightful about this is that, you're talking about these 3 layers of employee benefits. Again, for small and medium-sized businesses, for companies who are looking to attract and retain great people.
Yep.
These are things that you need to understand, because if you don't want to understand them for your people, someone else is going to understand it for them better than you.
Yep.
And they're going to walk, right? They're just going to go over there because they do a better job of it. Isn't that true?
100%. I mean, let's just talk about GLP-1s. There was a survey last year, and it's found like 2/3 of employees said they would leave a company for another company that offered GLP-1 coverage.
2/3.
Yep. 2/3. So if you think about that, and rightfully so, employers should carve out GLP-1 coverage. They shouldn't actually have that in their insurance plan because it's jacking up their premiums. But with that preventative healthcare program, if now those same employees could get access to GLP-1 coverage for $225 a month with still like a doctor and nurse helping them prescribe and understand the dosage, well, that is a way to attract and retain talent and have them pay about 70 to 80% less than what they would pay in the market.
And when you compare that to a downstream effect of a diabetic patient a diabetic team member or employee that needs to take an extra, on average, 3 to 6 weeks vacation per year for health-related events. And in addition to that, all the extra expense of insulin on a monthly basis as an expense, the doctor and hospital visits as a monthly expense, possible dialysis as a monthly expense, all of these extra things, this should be a no-brainer. I mean, if we were going to your point earlier on, if we were going to put away pennies to save those kinds of dollars in our businesses or lives, it would be a no-brainer.
Right.
But because we don't think about it the same way, and because we've largely sort of disconnected our mind from even thinking about it in that way, I think we're stepping into this murky place. I just can't believe that number. 2/3 of Americans would leave a company for GLP-1 coverage.
Yep.
And that's before we even get into some of the more groundbreaking stuff that's coming around the corner, which is even more exciting.
Correct.
So, Dan, I'm really grateful for having this fun conversation with you about
it has been fun.
what's a pretty complex subject, and you've made it pretty simple. And I think it's also very, very, the way that you've talked about it is very accessible to the average person. So thanks for that. And, my gratitude for you flips me back to something that we've been doing in every episode. At the end of every episode, we ask our guests to shout somebody out, and it's actually a call out to a previous guest of ours. His name was John Rulin, who gave us a napkin many years ago, which is what you appreciate appreciates. And his theory was you put more gratitude and appreciation in the world, everybody appreciates and value, not just for your relationship or in your dynamic with them, but just in general.
Yeah.
So he suddenly passed away coming up on 2 years ago, and ever since then we've been asking our guests to pay forward his message of gratitude by shouting out somebody. So is there somebody that you'd like to shout out to close our episode today?
Well, two in particular. One, again, Tom Wheelwright. For people that want to understand how the tax code is written so they can ultimately use it to their advantage as a business owner or as an employee, take the time to read his stuff. It is really powerful information. On a more personal note, though, I want to shout out my employees over at Mental Health Matters, because they have been the pilot for all these programs 4 years later that we're bringing to clients. So if it weren't for them, willing to trust me as their employer to see all these different things and how it works, we wouldn't have a lot of these innovations being brought to the marketplace. So I really do appreciate all those employees over there who continue to do an incredible job serving the community and creating affordable access to mental health care. So shout out to them as well.
And shout out to them for the work they do the rest of the time as well.
100%.
It's important work.
100%.
Thanks, Dan.
Awesome. Thank you so much.
Sometimes an idea kind of follows you out of a conversation, and I think Dan's napkin is one of those ideas. Make yourself obsolete before somebody else does, because it's easy to hear that as a warning. And I think maybe it's something else. Maybe it's permission to look at the things that are still working and ask whether they are still worthy of the future that you are building. Because most of us know how to respond when something breaks. The harder work is really questioning the thing that has not broken yet, the system that still produces results, a relationship that still sort of functions, the process that everyone understands and operates within, the expense that everyone has simply learned to accept, even if it keeps on growing. Dan's work in healthcare gives us this very fascinating example of what can happen when somebody refuses to accept the inherited answer. He became an employer. He wanted to take care of his people. So he looked at what was available, and instead of assuming that expensive meant better or familiar meant safe, he started pulling at the threads. Who gets paid? What are they rewarded for? What happens when costs rise? Who benefits if the complexity increases? And perhaps most importantly, are the incentives aligned with the outcome we actually want? And that's a question that's powerful for healthcare, but it's also powerful for leadership, because every business eventually accumulates a system that was designed for another moment, a different moment. That might have been when we created them. It may have even really helped us to get successful. And then almost invisibly, we can begin serving the system instead of asking whether the system still serves us. Dan talked about Kodak, and we talked about Netflix. One predicted what it had, and the other became willing to disrupt what it was already doing and working. And when you've built something real, that distinction becomes increasingly important, because the next threat to your business may not arrive looking like a threat at all. It may simply arrive as a better answer, or a crazy, freaking outrageous answer. It may be a better experience or a really clunky one that's hard to do right now. It may be a better way of taking care of people, or a competitor willing to question something that you stopped questioning a long time ago. So maybe there's something worth carrying from this conversation. And it's not that everything old needs to disappear, or that change itself automatically is progress, but there are moments, maybe little moments, where leadership asks us to look directly at what we have built and become willing to change it before necessity removes the choice. Perhaps you already know where that question belongs. There may be something in your company right now everyone has learned to live with, something that people call normal, something that costs a little more every year, and maybe that's the place to begin. So take out a napkin, write down the thing that you might be most afraid to make obsolete, and then sit with something else. If we were building this business today, knowing everything that you know now, would I build it this way again? Because sometimes the next version of the company doesn't begin by adding something new. It begins by becoming willing to release something that belonged to the last version. So I really want to thank you for joining us. And Dan, thank you for reminding us that sometimes one of the most responsible things a leader can do is to become willing to make something obsolete before someone else does. This is Paper Napkin Wisdom. Keep thinking big, start small, and perhaps start with a napkin. I believe in you. Make it a great day.